Okay, good morning, everyone. Thank you so much for joining us today. I also want to thank Dr. Kern for taking some time out of his morning to present for us, and also to Boston Scientific for sponsoring this webinar. A couple of housekeeping items before we get started. There will be a Q&A session at the very end, and we'll ask all the questions then. There are a couple of different ways that you can submit those questions. The first, if you navigate to the GoToWebinar control panel, there should be a questions tab. You can type your questions in there. Those will come directly to me. If they are technical questions about audio or video, I will answer them right away. But if they are more related to the topic, I will hold those until the end and ask them to Dr. Kern. The other option to asking questions is you can raise your hand and ask the questions verbally. There should be, in your control panel, there should be a little icon that looks a little bit like a hand. I'll be notified if you click that, and then I can unmute you and you can ask your question directly. If you choose to do this option, please make sure that your computer is equipped with a microphone so that way we can hear you. There were a couple of questions also that were submitted during the registration process, and we'll be sure to get to those as well. Additionally, there will be a follow-up email sent out tomorrow for this webinar, and there will be a recording of the session there. We actually have one upcoming program, and that's going to be actually later today. It's an introduction to PD Self. It's the third session of our Parkinson's 101 series, and that will be from 4 to 6 p.m. PD Self, if you're not aware, is a self-efficacy learning forum that was started here in Denver, but is now a national organization, and it's a great topic. So if you're interested, please feel free to visit www.parkinsonrockies.org/online programs, and you can register there. And with that, I think that's all for me. So I'm going to go ahead and transfer over power to Dr. Kern.
All right. Well, thank you, everyone, for joining me. I assume that you can all see my screen. Please let me know otherwise. So I was asked to give an overview of advanced treatments in Parkinson's disease. Let me just give a little bit of movement here. So I think it's best to first introduce ourselves, who we are at the University of Colorado Movement Disorders Center. And I'm going to give an overview of advanced treatments in Parkinson's disease. We're then going to dive into DBS and focusing really on Parkinson's disease with DBS. So who are we? So we're a large group of clinicians, researchers, nurses, physician assistants. The core group consists of 6 fellowship-trained movement disorder neurologists. And what that means is all of us are neurologists, so we've completed a residency training in neurology. But we've gone on to complete at least probably 2 and even up to maybe 3 years of advanced training specifically in movement disorders. We only see patients with movement disorders. But we're a much larger team than this. We consist of 37 clinical personnel, as you see. We span 7 different departments, from neurosurgery, neuroradiology, physical medicine rehabilitation, psychiatry, our therapists, which include physical, speech, and occupational therapy, ear, nose, and throat, neuropsychology as well, and neuropalliative care and behavioral neurology. We're located in a number of different satellites. I'm not sure if many of you knew this, but we have clinics up in Fort Collins, in Boulder, actually right after this webinar. I'm going to Boulder to see patients. We're in Denver, also in Lowry, and finally in Lone Tree. There's always talks about having us even expand beyond these regions as UC Health opens up more satellite clinics. We're very proud that we are part of the Parkinson Foundation Center of Excellence, which you can see here consists of 34 United States centers. And these are centers that have been deemed through an application process to provide excellent care in Parkinson's disease for the entire patient. We're the only center really within the region and certainly within our state to have this designation. At the university, we've developed an advanced treatments and movement disorders program. And this came about because we became acutely aware that a number of our patients really were not receiving adequate care that they potentially could be benefiting from. So it may surprise some of you that 45% of patients with Parkinson's disease do not have a neurologist involved in their care. And this doesn't even include a movement disorder neurologist. This is a general neurologist. Commonly, there is an incorrect perception that in the later stages of Parkinson's disease, there's little that can be done, and this is simply not true. We know that the care provided by a neurologist, again, general neurologist, not even specific to a movement disorder neurologist, is associated with greater utilization of cost-effective therapies, results in fewer hospitalizations, less risk of having fractures. Think about falling and having a hip fracture. That can actually be devastating to a patient. We can improve a patient's mood, and we're associated with that, as well as we are associated with reduced nursing home placement. Consequently, there's good data that having a neurologist involved in your care is very beneficial to the patient. So we developed the CU Advanced Treatments and Movement Disorders program, and there's three main objectives to this. One, to promote education of physicians and patients. So as an example, what we're doing right now, but also to physicians, and this includes our colleagues in primary care, such as family medicine, internal medicine, geriatrics, and providing them with lectures and materials so that they know how to adequately treat their patients with the latest information, as well as to be a resource to them should they have any questions. We want to also, second objective, to provide patients with treatments that address their specific needs. You'll see later on in the presentation, there are a huge number of treatment options, and each one of these must be decided based upon the needs of the patient. There isn't a one-fits-all type of model here. And finally, three, to promote research in the development of the field of advanced treatments in Parkinson's disease so that we can even have better treatments in the future in the care of our patients. So let's start with a little bit of background. And this is very generalized, but I want to make sure that we're all on the same page here. So Parkinson's disease is due to a loss of neurons that produce dopamine. So it's due to a loss of dopamine. And you see here a cross-section cut of the brain, and I'll show you with my pointer. This portion of the brain is part of the brainstem, and it's called the midbrain. In this part of the brain, you'll see this dark pigmented area is what we call the substantia nigra. And this is where your dopamine-producing neurons are located. And you can see in somebody who's healthy, who doesn't have Parkinson's disease, in this cartoon, a very dark pigmented area representing the substantia nigra. Nigra obviously meaning black. However, in Parkinson's disease, you see that there is a loss of nigra, and this indicates a loss of the neurons that produce dopamine. Now, this is helpful for us all to remember, is that where these dopamine-producing neurons are located, example here within the midbrain, there's a number of different pathways that come out of this location. Dopamine is not purely a motor neurotransmitter, but is involved, and I probably don't need to, I'm preaching to the choir probably here, but is involved in a number of other physiologies, such as memory and cognition. And this makes sense when we look at where we see dopamine originating from and going to. For example, the mesolimbic pathway. Limbic is an area of the brain that's particularly involved in memory. Also, you see the frontal lobes are involved here. And so this is your involvement in maybe your personality, your impulse control disorders, and we'll cover that in a minute here, planning of movement, risk-taking or risk aversion, and then finally, as we see in the red, the motor pathways. And those motor pathways are called the nigrostriatal pathways. So let's go through some treatments here, okay? We're going to break this into three main categories. 1, medication, 2, novel delivery systems, and finally, surgical. In general, when we think about treatment for Parkinson's disease, we can break this really into 5 main categories. 1, we can replace dopamine. 2, we can prevent the breakdown of dopamine, meaning that we keep dopamine around in the brain longer. 3, we protect the neurons that produce dopamine from progressively dying. 4, maybe in the future, we could regrow these dopamine-producing neurons. As you may recall, we've tried this in the past, about 15, 20 years ago, and the University of Colorado was actually one of the centers that did the first trials, human trials, of stem cell transplantations. There were some problems that patients ultimately developed, that being dyskinesias, with this treatment option. And now we're back at the lab looking at, can we potentially modify these cells to be able to grow specifically into dopamine cells and perhaps even integrate into the neuron network. I question if that's really feasible. And right now we're also looking at, can we make these type of stem cells into producing growth factors. Growth factors are factors that are healthy, i.e. keep other cells around to survive. So basically, maybe we transplant, for example, cells that keep the other existing cells, the dopaminergic cells, alive longer. And finally, modifying the neural circuitry. And this is what we'll be talking about when we discuss deep brain stimulation. So this is not even a complete list of the pharmacological treatments available for Parkinson's disease, but we'll cover several of these in subsequent slides. We'll start with Carbidopa, levodopa. First of all, what we try to do is perhaps prevent the breakdown of levodopa or of dopamine. And those are produced by shown here, two main type of inhibitors. COMT inhibitors, Carbidopa, which we'll talk about, as well as MAOB inhibitors, okay? And then we also have, as you see here, levodopa. Now, levodopa is a precursor to dopamine. Levodopa becomes dopamine. So when you take levodopa in, it goes into your stomach, small intestine absorbs it, goes into your bloodstream. From the bloodstream, then, it's able to cross what we term the blood-brain barrier, get into your brain. Remember here, it's still levodopa. And your brain is able to then convert levodopa into dopamine. Perfect. Carbidopa simply prevents levodopa from getting broken down into dopamine, okay? And it does so in the stomach, small intestine, and in the blood. Carbidopa cannot cross the blood-brain barrier. So carbidopa stays, we would say, in the peripheral system and not within the brain. One question I get asked by my patients is, so why can't I just take dopamine? If Parkinson's disease is due to a loss of dopamine, why can't you just give me dopamine? And the reason is that dopamine cannot cross what we term the blood-brain barrier. Dopamine, consequently, will go to a specific area of the brain which is involved in nausea. Consequently, if I was to just give a patient dopamine, the only thing that will really happen is that the individual will get nauseous and vomit. So what you see here is that levodopa goes into the brain, becomes dopamine, and that's excellent. And then if we go back one slide here, carbidopa prevents levodopa from becoming dopamine. But carbidopa can't cross the brain. Therefore, carbidopa is always given with levodopa, so that it keeps levodopa as levodopa in the peripheral system until it's absorbed by the brain. The combination, by the way, of carbidopa-levodopa is often we term cinemet. And that's simply shown here when we demonstrate that levodopa goes into the brain, carbidopa cannot. And this is excellent because we want to keep levodopa in the peripheral as long as possible until it's absorbed into the brain. There are a number of different formularies of levodopa, and this becomes confusing. There's carbidopa-levodopa immediate release, we term cinemet. There's carbidopa-levodopa controlled release, which we call CR. And I'll point out that we used to think that carbidopa-levodopa CR was going to be a great treatment for our patients. They would only need to take carbidopa-levodopa 3 times a day. Unfortunately, that didn't really pan out. And it really only increased the longevity of a regular cinemet on the order of maybe 30 minutes, if you look at the half-life. And carbidopa-levodopa CR, however, is only 75% as potent compared with immediate release. Consequently, rarely do I actually prescribe carbidopa-levodopa CR for daytime use. There's also Stalevo. Stalevo is a combination of 3 medications, carbidopa-levodopa, as well as entecapone. Entecapone prevents the breakdown of levodopa in the peripheral system. The nice thing I'll point out about Stalevo is that it comes in different formulations of levodopa. So it comes in a 50 milligram, 100 milligram, 150, and a 200 milligram dose shown here. What's nice about this is obviously a patient wouldn't have to necessarily cut the medication, and they can take just a single pill. Then we have Ritari. Ritari is also termed carbidopa-levodopa extended release. And this truly is an extended release form of carbidopa-levodopa. What they've done is they've taken carbidopa-levodopa and they've encapsulated it into different type of beads. And there's 2 main different type of beads. One of the beads dissolves immediately and the other bead dissolves in about an hour to 2 hours. So what ultimately happens is you get an immediate release, and then you have a slightly delayed release form of levodopa. And you can see that they put these different beads within a single capsule. One important point here is that the dosages of the levodopa in Ritari are not equivalent to the dosages that are in immediate release. So 195 milligram dose of levodopa in Ritari is somewhat more equivalent to 100 milligrams of levodopa in immediate release. So it's not a 1-to-1 ratio. And I unfortunately have had patients referred to me who were converted 1-to-1 on Ritari and were doing miserably. But when you look at it, essentially what the physician had done was cut the medication in half by doing that conversion and not doing the conversion correctly. And finally, we have inhaled levodopa. You'll notice here that carbidopa is not part of that. Consequently, patients would need to be on carbidopa with this. Otherwise, again, what's going to happen? Well, levodopa is going to be converted to dopamine and the person's going to become nauseous. Questions that I often get is, why do I need to make medication adjustments? Why do I keep having this be my movement disorder neurologist over the period of time? And the reason is because all of our treatments are really symptomatic treatments. And I commonly will use the analogy of a cough drop. Imagine that I'm practicing medicine years ago in the age before penicillin, and you're coming in with a sore throat. And let's pretend that you have strep throat. At the present time, although we're working very hard at the university, I do not have, using the analogy, penicillin to eliminate the strep throat. Instead, what I have are really good cough drops that will make it so that you do not feel like you have strep throat and you can live out your day. Obviously, a cough drop does not do anything for the progression of strep throat. And as the disease progresses, we consistently need to make medication adjustments. This includes either shortening the time interval of medications, increasing medication, adjunct medication, or some of the advanced treatments that we'll talk about in a few minutes here. In addition, there's also this window that you see here, the therapeutic window. And what this equates to and means is, if you see in the pink-red color, is the dose that would need to be taken until the individual finally starts to notice some form of benefit shown in green, until they start to develop what we term dyskinesias. And dyskinesias are abnormal wiggling movements. You can think, for example, of Michael J. Fox giving his presentation in the Congress several years ago. That's an example of dyskinesia. And as time goes on in the disease, the window from when the individual starts to notice benefit to when they start to have adverse effects shrinks over the period of time. I also get this question, especially in the early course of the disease, that, quote, if I miss a dose, I don't even realize it. So do I really have Parkinson's disease, doc? And the answer is yes. And the reason why you can miss a dose is because, again, shown here is a dopamine neuron that then is connecting onto a striatal cell, another neuron. And dopamine is shown here in the purple. Again, levodopa becomes dopamine, gets taken up in a vesicle, and is released across what we term the cleft onto the other cell. However, what's important here is you still have, in the early stages of Parkinson's disease, you still have some dopamine neurons. So the dopamine is released, but then it's able to be recycled back up into the cell and reused again and again and again. Hence, in the early stages of the disease, what we would term the blood levels do not match the actual brain levels of the drug, because you're continuously reusing the drug over the period of time. However, as you imagine, as the disease progresses and these cells start to die off, as soon as levodopa becomes dopamine and goes across to the cell, there's no other cells to actually retake it back up, and it becomes dissolved. Another question is asked, can levodopa cause dyskinesias? And this was a pivotal trial that was done, giving patients either levodopa early in the course of the disease compared with delaying giving levodopa. And you can imagine how that study is ethically would not be able to be done, but it was able to be done in this context. A group of Italian movement disorder neurologists were comparing patients who they were treating in Italy and giving them medication immediately, which is standard of care. You can see the time period from when they developed symptoms. Some of these were started very much early on, and then they follow them over the period of time, simply looking at when they developed dyskinesias. These doctors also had a clinic in Ghana, and unfortunately in Ghana, despite best efforts in asking to obtain medication, often these patients are not treated until very late in the course of the disease. You can see here 6-7 years in the disease course until they're finally given levodopa. These individuals, for example, would have even been bedridden. And then they compare the onset of when these individuals might develop dyskinesias. It tends to be around 6 years into the disease course that the individuals would develop dyskinesias. Patients who were never treated with levodopa could develop dyskinesias immediately. So that really told us that in actuality, it wasn't necessarily the medication. It was more the progression of the disease that related to the onset and development of dyskinesias. And this is assuming that medication levodopa is given appropriately. We have other medications, and these are termed dopamine agonists. What that means is that it's not dopamine, but it looks somewhat similar to dopamine. You should note that we have 5 different dopamine receptors. And these dopamine agonists, they tend to bind predominantly of note to dopamine receptors 2, 3, and 4, much less so to dopamine receptors 1 and 5. So they're not quite dopamine, but they're close. And you can see the names of the different medications provided up here. They really can be used at any time in the course of the disease, but they do have notable side effects. 1, low blood pressure, 2, sleepiness, and even some people will say sleep attacks. They can be associated also with leg swelling. And finally, impulse control disorders, and this needs some recognition here and discussion. Impulse control disorder means that we all have impulses in our lives, but we're able to stop and prevent us from doing these things. However, with these medications, they can cause what we say ICDs or impulse control disorders. And what does that equate to? Well, predominantly in men, that can mean hypersexuality. It can also equate to gambling. In women, interestingly enough, it can equate to binge eating and really craving sweets. So think about the tub of ice cream at night. Hobbyism, so you're constantly doing a hobby over the period of time. Shopping, looking at catalogs nonstop. We used to think that these were incredibly rare to occur. However, as we became more knowledgeable, it appeared that they're much more common, anywhere from 6 up to more into the range of 15% of individuals treated with these medications may develop impulse control disorders at some point in time in the course of the disease. Consequently, we started to think about not giving these as really first-line treatment, but maybe later in the course of the disease or after carbidopa, levodopa, the individual may be developing a little bit of what we term off symptoms, meaning they start to have more Parkinsonism between dosages of medication. That tends to be when I may use these medications, specifically in the treatment of Parkinson's disease. Some of you may be also taking this medication for restless leg syndrome, and it's an excellent treatment for restless leg syndrome. Another dopamine agonist is apomorphine. This is given subcutaneously, and it is a rapid onset of benefit. There is associated nausea, vomiting, or hypotension that can be associated with this, and medication to prevent nausea needs to be given. Of note, you may also have read that there is a sublingual form, meaning under the tongue type of strip, that just recently has been approved as well of this medication. There are other motor symptoms that we need to treat. 1, dyskinesias. And there are 2 main medications that are effective for dyskinesias, that being amantadine and clozaril. Clozaril is an antipsychotic. It's a very good medication, but the problem with this medication is you need to have regular blood draws. Tremor, anticholinergics. I tend to not use these medications as much because they tend to cause dry mouth, urinary retention, and more importantly, can be associated with memory impairment. And finally, dystonia, which means abnormal contraction of muscle groups that causes a twisting motion or an irregular tremor. And botulinum toxin injections can be very effective for this treatment. Now, as most of you all know, Parkinson's disease is not purely a motor disease, but there's a number of other symptoms that are associated with it, and not uncommon, a number of these symptoms can be more disabling for the patient compared with the motor symptoms. So, as an example, and given our limited time, we'll only touch on these, But dementia can be and is commonly associated with Parkinson's disease. And a reasonable treatment for this is indeed rivastigmine, which is FDA approved for Parkinson's disease dementia. Depression is often very common, and you see a list of medications that can be provided. Of note, many of you may be on these medications, as well as may be on one of the MAOB inhibitors. Those are inhibitors that, again, prevent the breakdown of levodopa. And there's a theoretic concern of serotonin syndrome. This really has not been associated with the MAOB inhibitors, but more with MAOA inhibitors, and we do not prescribe MAOA inhibitors. Hence, there's even studies showing that this is likely exaggerated, so it's very normal and fine for you to be on an SSRI or an SSNRI and still be on also with an MAOB inhibitor. Psychosis, as you see here, can occur, and this means hallucinations or paranoia. REM sleep disorder is very common and may even predate the onset of Parkinson's disease, and that means that the individual is acting out his or her dreams. So think about somebody kicking, fighting, getting the bad guys off, or dancing around. If they're dreaming that they're dancing, the person's actually asleep. So asking the individual, do you have REM behavior disorder, is actually not very helpful. You have to ask the bed partner. Constipation is very common. Drooling is common. And fatigue is actually probably one of the most common, and is the most common symptom of Parkinson's disease. So that's just a brief overview of the pharmacological treatments. And I think, as you can appreciate, there's a lot of medications and a lot of symptoms that we need to evaluate and discuss during an appointment time. Right now, we're going to switch gears a little bit and talk about alternative drug delivery systems. And there's a number of them. One of them is called Carbidopa levodopa enteral suspension, DUOPA or DUODOPA. This medication involves a gel form of carbidopa levodopa, which is held in a cassette shown here, that then is delivered by tube to an IV tube shown here, and that has another smaller tube in it that then is delivered directly to the small intestine. So this involves what we say a G tube, meaning a tube that goes from the stomach to the outside of the skin, and then a J tube, which means jejunal tube, that feeds through the G tube and into the small intestine, continuously delivering carbidopa levodopa. It's approved for daytime use, 16 hours, although I will tell you I do have patients using it 24 hours, and that is off-labeled use, however. When I have patients use this type of system, I need to tell them that we do anticipate the probability of developing adverse effects. The vast majority of these adverse effects are really related to the tube itself. It can be up to even 75% of individuals will develop an adverse effect. And you need to think about things like oozing around the tube gets pulled out, and I'm not meaning the G tube, but the J tube gets pulled out, and we have to put it back in. You can have irritation around the tube, infection around the tube, and these are mainly a lot of nuisances. But given the fact that you can continuously provide carbidopa levodopa, patients tend to do very well from a pure neurological perspective with this treatment. Another treatment option that is in clinical trial, and we have both of these clinical trials at the university, is subcutaneous carbidopa levodopa. You can see here the size of the pump. There is a new pump that I must be saying is coming out. You can see that it is a liquid form of carbidopa levodopa that goes to a tube that then is positioned to basically a patch needle. So this is a very small needle that goes just under the skin, and it continuously releases carbidopa levodopa. This is being looked at for 24-hour treatment. Neuroderm is one of the companies that is investigating this, and they've just completed one of their trials. And AbbVie is looking at this as well. They've just reopened up their open label study for this. We are actually recruiting at the university for that. And as well as have just started also their randomized control trial, hopefully starting up here within the next month or so. I can tell you the patients who I have on this type of treatment in the open label study are doing quite impressive and quite well. They need to change out this patch every 2 days or so. And they have had remarkable benefit with the continuous infusion, and it works very well. AbbVie is the same company who makes Duodopa, that's the carbidopa levodopa enteral suspension. And you can see that they're also looking at other forms at this point in time of continuously delivering carbidopa levodopa. There's also apomorphine. You already saw the pen form, the injection form of apomorphine, but there is also a continuous infusion subcutaneous form of apomorphine that we're expecting to be approved any day probably here soon. It is approved in Europe of note. You can see here that there is a dramatic improvement of off time. So this is in hours per day. It can reduce approximately 2 hours of off time. This is similar, I should tell you, to the Duopa data that we also have available. So now we're going to switch to the final portion of this talk, and we're going to spend some time on this because I know many of you may be interested or considering such options, and that includes neurosurgical treatment. So we need to talk about first, what does the word advanced mean? And there really is, unfortunately, in our society, no really great definition of the word, quote, advanced. You'll hear different terms from different individuals. I tend to use the term advanced when the individual is having greater than 3 hours to 4 hours of off time during the day, despite reasonable taking of carbidopa levodopa, i.e. taking carbidopa levodopa every 3 to 4 hours, and or they develop dyskinesias. And the dose of carbidopa levodopa is typically greater than, for example, 2 to 3 tablets at each time interval. Again, there's no clear definition, however, of this. We used to think that we should delay the onset of providing these advanced treatments until the individual is in the severe motor complication time period here. However, as you see by the red bar, we've really changed over this period of time and have moved this much further up into the disease course. And this was done because as we became more educated and more research came out about the benefits, it became apparent that patients treated with these advanced treatments did even better compared with individuals on best medical treatment, both in motor, non-motor, as well as in quality of life. Hence, it became fairly unethical to hold on to providing a medication, or in this situation, what we're specifically referring to is deep brain stimulation, until the individual was severely impaired. So why should we hold on to a treatment, given the great benefits that it can provide, until the individual loses his or her job, has family stress, marital stress, loses enjoyments that they previously have had, such as hobbies? Why shouldn't we offer this early in the course of the disease? Hence, we're certainly talking much sooner in the disease course about these more advanced treatments, given the notable benefits that they're associated with. In going through this, let's talk about some of the I would say they're still surgical in my viewpoint, but they do not require the use of a scalpel. One of the treatments that started off early in the course of surgical treatments for Parkinson's disease, and certainly that of tremor, is gamma knife radiation. Gamma knife radiation involves providing gamma rays of radiation to a specific vector. And so you have all these gamma rays converge on a common point, and that creates cell death. And that's shown here, okay? This is a treatment that can be used for tremor. However, some problems we do know about this treatment, and that includes it takes time for these cells to die. Hence, we do not see the immediate results, and it can be even delayed, up to beyond 6 weeks. So after you come in for your treatment, you probably do not look any different compared with when you came in, and you're waiting to see what the results will be. The greater concern I have is what we term a runaway lesion. And this means that we've radiated a portion of the brain, and that radiation continues to occur, and more cells die over the period of time, and that is shown here. So optimally, you may want only this portion of the brain to lose these type of cells, tremor cells, but unfortunately, it progresses much more dramatic than that, and you can see something like this. And really, we tend not to do gamma knife radiation surgery anymore. A new treatment that you may be much more aware of is that of focus ultrasound. And what this does is, using a similar concept that of gamma knife radiation, is you have a common vector or point that you align all your ultrasound rays to, and that creates heat. So rather than radiation, it creates heat and creates a thermal burn. And that is shown here. And again, the gamma knife radiation, as well as the focus ultrasound, are treatments for tremor. They're not necessarily treatments for the other symptoms of Parkinson's disease. And you can see here on the top the duration of time that they're providing the ultrasound to be turned on, and the heat map that they generate. So you can really see the area progressively becoming hotter and hotter and hotter. But in addition, because we're not waiting for a delayed effect, we can actually see right there within the scanner, are we providing the patient the clinical benefit that we're looking for, as well as assess for adverse effects. At the university, prior to COVID, we had planned to obtain one of the focus ultrasound machines in the early summer. Actually, it was planning in June. However, given COVID, we are delayed in obtaining this, so we're waiting to hear back from the hospital when we were going to be able to obtain this equipment. The results are very good for tremor, again, and you can see here the long-term benefits that are provided with a dramatic improvement of 50 to 75%. I will point out, however, that a number of patients have had a notable progressive worsening of their tremor over the period of time. And a number of these patients, and this is pioneered really at the University of Virginia, a number of these patients have subsequently gone on to deep brain stimulation. The treatments that we've discussed thus far, the focus ultrasound, as well as gamma knife radiation, again, are really treatment options for tremor. And that's because we target an area of the brain called the thalamus. And what we're really doing is what we term a thalamotomy, which means we're lesioning, burning, removing a portion of the thalamus. I'll point out that years ago, we used to do this via a scalpel, where we would place an electrode down into the brain with the tip positioned right here where the arrow is, and provide through the electrode radio frequency and create a burn at the tip of the electrode, very similar to what focus ultrasound is now able to do without needing to place an electrode deep into the brain. Of note, some benefits of this: it's a single procedure, there's no hardware. The costs are still being evaluated, and it does involve fewer appointments, and in part because no adjustments are able to be made. The cons, well, it's permanent. You can't really adjust anything. A burn is a burn. The only thing one could do is increase the size of the burn. And there is notable concern about performing a bilateral, both sides of the brain type procedure to be done because of worsening cognition and potentially of speech. That leads us then to deep brain stimulation. Deep brain stimulation involves the implantation of an electrode deep into the brain, and there are specific regions that we target that I'll show you in the next slide or two. It involves continuously delivering electricity to specific structures of the brain. It is reversible somewhat, and what I mean by that is, yes, some of the hardware can be removed. However, we tend not to want to remove the electrodes in the brain for concern if we do so and you pull out the electrode, that can increase the risk potentially of a bleed. It is certainly adjustable, however, in the aspect that we'll show with the electricity that can be provided. And involves placement of electrode here that you see, and I'll show you with the arrow, deep into specific structures of the brain. There's a cap, again, on top of the skull. All of the equipment, by the way, is under the skin. This cap then connects to another wire shown here, and this is a connection wire that runs typically behind the ear, positioned to a battery, or we term implantable pulse generator. That's right below the clavicle in the chest. There are a number of different electrodes, and we'll cover some of these in subsequent slides. And there's also, of note, 3 different companies who make deep brain stimulation at the present time. The first DBS procedure was performed back in 1989 in France, and you can see the dates as to when it became FDA approved, and this is DBS in general, okay? The essential tremor in 1997, 2002, Parkinson's, dystonia, on humanitarian exemption, 2003, as well as an OCD. And also of note, has recently become approved as a treatment for epilepsy. Again, though, we're targeting different parts of the brain, but using similar equipment. Successful DBS involves a number of different components. 1, we must have appropriate patient selection. 2, we must do a very good job with our surgery. And finally, programming. The surgeon can place the electrode in the ideal location. However, if the programmer is not experienced, then the outcomes are going to be suboptimal. And we'll cover each one of these in the subsequent slides. So let's start with patient selection. It's well known that success of DBS involves a multidisciplinary team. If you do not have a multidisciplinary team in conducting DBS, I would argue that then one should not be considering at that center, actually not a center, to consider using DBS at that location. You can see the individuals involved in our DBS program. From neurosurgery, neurology, we have a total of 4 movement disorder neurologists all trained on DBS, neurophysiology, neuropsychology, neuroradiology, supportive care, psychiatry, number of individuals involved in physical therapy, occupational therapy, speech therapy. We have a designated DBS nurse and DBS coordinator, scheduler, and a research coordinator. So how does this work? So an individual is either referred to us directly for DBS evaluation from one of our community movement disorder neurologists in the private sector, or directly from one of the providers within the CU health system. I will point out, though, that if an individual is referred for an DBS, for example, from a general neurologist, we tend to first offer a clinic appointment with one of the movement disorder neurologists to discuss advanced treatments and evaluate if DBS is really the right course of action that we want to pursue with the patient, and that the patient would like us to pursue this. The next thing that we do, if indeed we pursue DBS, is a number of appointments are already arranged. All of these are completed over a 2-day period. One, you've seen the movement disorder neurologist, and you see the movement disorder neurologist in the on and off medication state. Typically, that is done after the individual has stopped medication overnight. I then will see the patient first thing in the morning, 8 a.m., for example, evaluate the patient, and then give the patient medication, and then evaluate what they look like, quote, on medication. The reason why that is important is symptoms that tend to be improved with medication, with the exception of tremor, are ones that are improved with DBS. An exception of this is tremor, which may not be fully improved with medication, but responds very well to DBS. The movement disorder neurologist also reviews the goals of the patient to make sure that they're aligned with the benefits that can be provided with DBS, as well as ensures that this is a correct diagnosis, in this example of Parkinson's disease. And I've unfortunately seen a number of patients who have what we term atypical Parkinsonism. And the reason why they're not doing well is because they actually don't have Parkinson's disease. And in those individuals, DBS really is not a very good treatment option. Review with the patient any past medical history that may be a concern. Review with the patient as well as social support, as well as go over furthermore what DBS entails, and we'll cover that in subsequent slides. Patient also is seen by neuropalliative care, and that's a unique aspect, and we're actually writing a paper on that right now that we have at the university. And I find this important because although I may concentrate on the motor aspect about the patient, neuropalliative care concentrates on the overall goals of the patient. So, for example, I might concentrate on, okay, you want to reduce your tremor, okay, this treatment can improve it by 70 to 90%. But palliative care might say, okay, you want to be able to dance again. You might want to be able to do fine crochet again, knitting again. You want to play with your grandkids again. What are the playing that you do? They also look at the overall network of the patient, because Parkinson's disease, as you know, does not just affect the patient, but the entire family and friends. And they also evaluate if there's any concerns of depression, anxiety, as well as reviews any other red flags that they may see. The individual also is given an appointment with neuropsychology. That's a 6-hour appointment. They do in-depth cognitive testing. And the reason that's important is because individuals who have cognitive impairment are really not good candidates for deep brain stimulation. If an individual has cognitive impairment, there is a possibility that DBS may worsen their cognitive impairment and make them furthermore demented. So this is obviously important that we perform this diligently for all of our patients. Individuals also are provided an appointment and see the neurosurgeon who goes over the real risks of DBS, as well as you obtain a brain MRI. We prefer that actually at our institution because we've developed some sequences that allow us better to see portions of the brain that we would like to target in DBS. Again, all of that is conducted over a 2-day period. We have a coordinator who arranges all that for our patient. A week thereafter, Tuesdays, for example, at 7 a.m., all of those individuals that you see here, vast majority of them, sit down at a round table, literally, and we all talk about the patient. We obviously do this virtually at the present time, given the restrictions of COVID. And we discuss going around the table, the individual, and if there's any concerns. So, as an example, I would start with the individual and go over the goals, the disease, the diagnosis, the improvement on off medications, any concerns I see. Neuropalliative care would discuss. Neuroradiology then is there and shows the images and reviews the imaging with the patient. We also have neuropsychology and reviews the psychological profile and any concerns that they saw. Neurosurgery then discusses what they discussed during their appointment time, and then we go around and evaluate, is this a good option for the patient to consider DBS? 3 options are then provided. 1, the patient is approved for DBS. 2, sometimes more investigation is needed. Sometimes we might uncover something, for example, during this whole evaluation process, or unfortunately, the patient is really not a good candidate for this. We then provide and contact the patient that day or even the following day about the outcomes of this, and provide follow-up appointments as needed. In the event that the individual is approved for DBS, they then see physical medicine rehabilitation who evaluate any potential rehab needs that the patient has now, as well as can be anticipated with DBS. Surgery is then performed, and we have dates provided for surgery, as well as prior to the individual even going into surgery, all follow-up appointments are made. That way, I find that important so that the patient knows that they're going to be taken care of throughout the entire process. These are some very general patient selection exclusion criteria. We already touched upon the cognitive impairment issue. Obviously, if the individual has cardiac, renal, liver, lung problems, cancer, hypertension that's not adequately treated, really in general, that just means that they're not a very good surgical candidate. If they have significant psychiatric illness that it is not being adequately treated, this could potentially worsen after surgery. So we want to make sure that's appropriately addressed. Obviously, if we see anything that's a concern of a bleed on the brain MRI, this would be a concern for surgery. We need to make sure that it's appropriate indication, i.e. correct diagnosis. And symptoms that tend not to be improved with DBS, with levodopa, with the exception of tremor, tend not to be improved with DBS. So an individual, for example, who says, I have a lot of balance problems, and this doesn't change at all with medication, and if that is their main goal, is to improve their balance, that's not really a symptom that would improve with DBS. Hence, the goals of the patient do not necessarily in this situation align with the realistic expectations of the symptoms that can be improved with DBS. I alluded to this earlier, but there are 2 main targets that we use for deep brain stimulation in the treatment of Parkinson's disease. And that includes the subthalamic nucleus, and that's shown here. And I'll point out that this area of the brain is called the thalamus. Hence, it's below sub of the thalamus. And another part of the brain that we call the globus pallidus interna, which is shown over here. Again, the target that we use for tremor is the VIM nucleus, which is a nucleus of the thalamus that's shown here. However, as we already mentioned, slowness of movements, rigidity do not improve with this treatment here of the thalamus, but these symptoms do improve if we target the STN as well as the GPI. Hence, these are the reasons why we tend to target the STN and the GPI in Parkinson's disease. Within the United States, North America, there are 3 main manufacturers, as you see here, Medtronic, Abbott, and Boston Scientific. We offer all 3 of these at our institution. They all have unique characteristics, and we review with the patient the pros and cons of each one of these to ensure that the patient is involved in the decision-making with us in which product is optimal for him or her. I'll point out some details that need to be considered just to give you a flavor as we go through the discussion about product. One of them is this term directionality. And as you can see here, if we go back one, an electrode consists of 4 main contacts. These are where, through the contacts, we can deliver the electrical stimulation. Okay. Newer electrodes now, as you see here, have these middle two contacts we call segmented or divided into threes. And that allows us to stimulate through any one of these three areas or combination, and as we'll talk a little bit about fractionation, even more ability to direct the electricity. And what we're showing here is if you had only this contact being used, i.e. there was no segmentation or divided into threes, you get this round area of tissue that is activated or volume of tissue activated, or the stimulation is provided in this type of region. Now let's pretend, however, that we do not want to stimulate over here. And let's say that if you stimulate over here, the individual develops pulling of the face. Well, the only way you could possibly do that and eliminate that is to reduce the actual amount of stimulation. But let's say that you want to still stimulate over on this area because it's helpful for the Parkinson's disease. With the newer directional leads, we can actually then, we would say, steer the current away from these areas of the brain that we do want to avoid and direct it to other areas of the brain that we want to actually stimulate, and that's shown here. There is now some very good data that these directional leads do provide a superior benefit to our patients compared with what we would term a non-directional lead. One study that was done is the progress study, and you can see the number of individuals that are involved in this. They did do an interim analysis of 66 patients. And they found that 89% of the patients had a wider, what we call therapeutic window. And that means from the time of increasing the stimulation to when they first develop benefit to when they develop adverse effects. So you want a really large window. And they found that this was dramatically improved with directional lead. Not only that, but they found that benefit could be achieved even with less energy. And there's other studies also done looking at this that have further verified these type of findings. I'll point out one other finite detail, which is Boston Scientific now has the ability not only to provide stimulation, for example here, to just this contact, but you can divide up as a percentage the amount of stimulation that you want to each individual contacts along. So imagine I can give 25% here, 50% here, and another 25% of stimulation up at this contact. So there is a greater range of availability to be able to manipulate the volume of tissue that is activated. This is ongoing research to see if this form, what we term fractionization, is actually of greater benefit compared with not having this type of feature. And we are working with Boston to evaluate this at the university. There is also, of note, a difference in the batteries. So we have different types of batteries, as you see here. Some of these batteries are rechargeable, shown here and here, and some of them are not rechargeable. And we, of course, discuss all this with our patients at the time when we're evaluating which product is best for the patient. Next, let's discuss surgery. During surgery, we really work as a team at the university. Shown here is Dr. Steve Ogeman and Dr. John Thompson. Dr. Ogeman is a neurosurgeon. Dr. Thompson is the neurophysiologist. What a neurophysiologist does is evaluate the recordings obtained during surgery to determine if we are indeed in the correct area of the brain. The patient comes in early in the morning and has imaging performed. We then merge the imaging with previous imaging that was obtained and target, I evaluate within that individual the exact location that we think we need to place the electrode. Again, we all work as a team. I'm obviously also here, but I'm holding the camera. So let's see kind of what that looks like. This is an individual's brain shown here, and this is an example of where the electrode would be positioned within the brain. This is done while the patient is consequently being moved into the operating room, and we do this the day of surgery. This is actually quite unique in the aspect that we can look at these white matter tracks that go along the area of the brain to make sure that we're not positioning right there along where the white matter tracks are, but also this is what we would use tractography for to make sure that, in fact, this area of the brain here, which is the thalamus, we really wanted to target for this individual, comes from the area of the brain called the cerebellum, with these white matter tracks feeding this area. I mentioned that we have improved our imaging technique, and this is a sequence that we've developed, and the STN is very well visualized with this sequence, but also, as you can see here, this area of the GPI, hence we've even been able to better improve our imaging to better target these structures when we're doing what we call mapping, and mapping is what we did here with Dr. Ojan and Dr. Thompson and myself. Another unique aspect that we have at the university is the ability to have neurophysiology. What this means is that we record particular regions of the brain, and these different regions of the brain give us different cellular signatures that tell us where the electrode is exactly positioned. And that you can see here, where certain parts of the brain give us different recordings. Not only that, but in the operating room, if, for example, we're targeting the STN, I can ensure that not only we are within the STN, given the cellular signature of this area of the brain, but we're also in the motor area of the STN. So the patient in this example is awake, and I'm having the patient do a number of different movements to make sure that indeed we are really not only targeting the STN, but getting even down to the details of targeting that specific substructure of the STN. And this is an example of what that would look like. I'll point out also, this is what we call an O-arm. So the patient is actually also has imaging performed even during the operation. So we had imaging done before, we have neurophysiology that is done during, and then we'll also see a little bit later, we have clinical assessment during the placement of the DBS electrode. In other words, we turn on the DBS electrode to determine, did we get the benefit, the effect that we're hoping for, such as, is the tremor completely gone? And then we also do another imaging while the patient is in the operating room with the electrode in the brain to make sure and say, is this exactly where we wanted to target prior to when we were doing our mapping? So there's a lot of redundancy that we use at the university to make sure that we are really targeting and getting the results that we and the patient would want. I don't know if you can hear this. I'm going to pause it right here. Patient's moving up and down. You may hear in the background those cells going bum, 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 bum. That tells us that we are indeed within the motor portion of the STN. If you look up here, you can also see this increased activity that corresponds when the patient is reaching. That tells us that indeed we are really in that area of the brain that's involved with the hand movements, as well as sometimes we can hear tremor cells that tell us that is indeed the part of the brain that we want to target. And I think, watch his tremor. And look at the tremor also that you can see up on the monitor here. And when he comes down, you can really see that increased activity. Behind right here is Dr. Ogeman. And watch the tremor come back and how that corresponds then with the recordings that we're obtaining here. So I don't think you have to be a doc to realize that we really are targeting this area of the brain causing this type of tremor. And even I've had patients say, that's my brain. Those sound like tremor. That sounds like that's directly related to my hand tremoring. I think that's probably a good spot, doc. This is what I was alluding to, is then we do an imaging of the electrode itself to indeed verify that we're really happy with the placement of the electrode while the patient is still in the operating room. And you can see here, this is what we, in green is the STN, and you can see the electrode, which is done in our cartoon, but has already been taken from a CT scan from essentially, from the O-arm, with the contacts positioned right within that dorsal portion, lateral portion of the STN shown here. After that, then the patient is admitted typically overnight to the ICU. If everything looks fine, they're discharged typically the next day. Highlight portions that I've already noted about our program is we offer all 3 DBS manufacturers. We perform intraoperative monitoring that includes neurophysiology, as well as by myself, a movement disorder neurologist. Again, we turn on the electrode and we determine if we're happy with the placement. Over here, this is Dr. Thompson standing here doing the electrophysiology. Behind him is Dr. Ogeman and then myself. Another really hot topic that is commonly discussed is the sleep DBS. We do a sleep DBS. When you do a sleep DBS, you really are relying upon imaging and imaging alone. Hence, we do a sleep DBS with an MRI machine with clear point. And we have quite a bit of experience using MRI-guided sleep DBS. We do not rely purely just upon a CT scan to perform this type of operation. And shown here is the MRI machine, the patient's asleep, and you can see here the probes that we end up implanting into the brain during a sleep DBS procedure. Next, let's talk about programming. After surgery, approximately 3 weeks after surgery, the patient comes for programming. The reason we wait 3 weeks is we want the brain to completely heal prior to delivering of electricity through it, because as the brain is healing, the electrical properties are constantly changing. We, during these appointments, review any symptoms that have changed, review again medication, and perform a detailed neurological examination. We also perform a detailed movement examination and perform a number of scales as shown here, based upon what the indication was and the target. We perform a skin examination to make sure that there's no protrusion of, for example, a wire or any hardware, or any early onset indication of infection. We then program the battery and we configure it, make sure that all impedances are checked and the battery looks good with regards to being able to hold a charge. We also review again the electrodes and where they're positioned. We did this actually, as you may note, even prior to the patient coming out of the operating room, but we review it again. And now we're thinking about what contacts that we're going to program. Next, we performed an assessment of therapeutic window, and I'm going to show you that in another slide. I've already kind of mentioned that in a previous slide. But one of the biggest challenges that we have is which contact do we want to stimulate from? Shown here is 4 of the contacts. And of note, there's a variability of not only which contact, but you can do you can stimulate through both contacts. You can stimulate through one, setting it as a negative, the other one is positive, or now with our directional leads, you can stimulate portions, or even now with fractionization directional leads, fractionate current along any one of these combinations. Traditionally, how we do this is we evaluate what we term a therapeutic window. So that's when you program, you keep parameters the same with the exception of either voltage or milliamps, and you gradually increase the voltage or milliamps until you see clinical benefit. So let's think about tremor. If the person starts to all of a sudden develop benefit, let's say at 0.5 milliamps, that's when we say, 0.5 milliamps was when we started to note benefit. We continue to increase the current or voltage until the individual develops some form of an adverse effect. That can include, I feel kind of funny, doc. I feel lightheaded. I'm feeling like my speech is a little slurred. I have a little bit of pulling on my mouth, I feel. That then gives us a window for when we notice the benefit to when we notice the adverse effect. And the greater the window, the better, the more likely that contact, an example here, contact 1, would be the contact that we would select. One of the great benefits about DBS is just the adjustability. And you can kind of see here, even with only having 4 contacts, we can adjust the stimulation on a number of different methods. But it gets even more interesting when we look at ability to adjust stimulation, shown here with the different directional leads, either by programming it, for example, on one contact, or you can program multiple different contacts to provide the benefit that we're looking for. Other parameters, just of note, that are adjustable include the pulse width, so how long we provide the stimulation, and then the frequency, how often the stimulation is delivered. Now, towards the end of the initial program, we make sure that everything appears to be optimized. We also can provide the individual limits, whereby they can increase and decrease the milliamps or voltage, or even switch to different program groups based upon restrictions that we provide. I know this can be very daunting and scary for patients, but we need to start thinking about it like saying, okay, if you start noticing having some form of symptoms of tremor, you can take an extra half a tablet of Carbidopa, levodopa. Most individuals by this time, if talking about DBS, say, yeah, that's not a problem. We have to think about it in the same context of if you notice a little bit of tremor, you can increase the stimulation by 0.1 milliamps up to an additional 0.5 milliamps, and you can't go above that because I've set the limit so that you can't hurt yourself. We teach the individual how to use the patient programmer, as well as if it's a rechargeable battery, how to recharge the battery. We inform of any points that need to be monitored. And medications commonly will need to be adjusted, especially if we're targeting the subthalamic nucleus. Hence, as stimulation, as you see here in green, is gradually increased, we consequently will need to gradually reduce medication. In subsequent visits, we make adjustments, review any programs or groups that are provided to patients, so we can give the individual a number of different programs that they can try and let us know which ones work better, and we may adjust and test different contacts. So let's get to the outcomes. This is an individual with Parkinson's disease who had a horrific tremor, as you see here. It was really predominantly on the right side of his body. You can see what his tremor was like before operating and after operating. And in this individual, we did target the subcortical laminic nucleus. He did have slowness of movement as well as rigidity. And this is after actually only 2 programming sessions. You can see that really that right hand is really just not functional for him at all. And no, the one on the right wasn't frozen there. He just really didn't have any tremor. There are 4 main pivotal trials that really looked at DBS compared with what we call best medical treatment. They looked at things like the quality of life and what we term the motor portion of the Unified Parkinson's Disease Rating Scale. And that's a scale that we use, as most of you probably are aware, to assess Parkinsonism, the motor portions of Parkinsonism. This one study was one of the first studies that was done. You can see that it was followed up at 6 months. And just to give you an example, you see the number of patients, so 78 obtained DBS and 78 obtained medication. And if we look at this here, you see neurostimulation is shown here versus medication. There was really no difference from baseline at 6 months. However, in the stimulation group, if we look at this, you see that this green area, which equates to increased mobility without troublesome dyskinesias, was dramatically improved, increased, by over, by 50% at least, compared with prior to surgery. Quality of life, as you noted here, and this is what we'll touch about in a little bit, was dramatically improved by 25%. That really means a lot, and we'll cover why that's important. And the Unified Parkinson's Disease Scale was meaning your overall symptoms were improved by about 40%. When we talk about which target, the GPI or the STN, they really are quite equivalent when we talk about the motor symptoms of Parkinson's disease. But there's one exception here that needs to be considered, and that's medications. With STN DBS, medication is dramatically reduced by even up to 50% or even up to 75% reduction. Hence, an individual who says, I'm just burdened by having to take medication every 2 to 3 hours, it's becoming very troublesome for me to live my life. STN DBS may be a much greater and more likely option to pursue compared with GPI DBS. This just gives a rough idea and the benefits that we can see. So, Unified Parkinson's Disease Rating Scale, your motor symptoms can be improved without medication by at least 50%. With medication, by improvement is like 25%. Activities of daily living, your ability to function during the day is dramatically improved. And you can also see that dyskinesias can be dramatically reduced. Dyskinesias are reduced with GPI DBS because stimulation of the GPI directly reduces dyskinesias, while dyskinesias are indirectly reduced by STN DBS because medication needs to be reduced by approximately at least 50%. So that's the motor portion. Looks great. What about non-motor symptoms? Well, we've learned that symptoms are also dramatically improved, non-motor symptoms with DBS. See here in yellow with this study, and this is shown up to 2 years. Everything in yellow is improved upon with DBS. Those not in yellow are not improved upon. I'll point out that the 2 main symptoms of non-motor symptoms that are really not improved are memory, cognition, attention. This is not improved with DBS, as well as mood, specifically apathy. Apathy meaning your motivation to do tasks, hobbies, etc. This is also not improved by DBS. This study did demonstrate, however, that sexual function appeared to not be improved with DBS, but a subsequent study that compared STN-DBS directly to best medical treatment did report an improvement of sexual function in individuals, and this is up to 36 months, compared with those who were treated with best medical treatment. Urinary symptoms of note were also improved with STN-DBS in this patient population. So we do see an improvement, no doubt, in non-motor symptoms. That's great. Let's talk about the quality of life, because that's what really matters to individuals. As I already kind of alluded to, most studies have shown at least a 20 to 25% improvement in quality of life, and that's shown here. This is the same study that we just showed in the last slide. They looked at quality of life, and you can see here at baseline higher score is worsened performance was 29, and it improved to 23. So about 20% improvement of quality of life in the study. Other studies have shown higher, up to 20%, 25%. But now let's look at these patients who were only treated with best medical treatment. Look at this though. Not only did quality of life not improve, but quality of life up to 36 months worsened, and that was significant. So not only is DBS improves quality of life, but compared with best medical treatment, at least with this data as well as in subsequent studies, best medical treatment actually progressively worsens quality of life over the period of multiple years while it's improved with DBS. There are risks. We do go through all of these risks with the patients because we want to make sure that we make an informed decision. Although rare death is a possibility with any form of brain surgery. Intracranial complications, meaning mainly bleeding of the brain, is a possibility. A number of these, however, are not symptomatic, meaning unless we actually did a picture of the brain, an MRI or a CT scan, we would not have seen that they had a small bleed. There is the possibility of having, as I've shown, an infection of the hardware or even skin erosion, and in that situation, the hardware needs to be removed or the lead might need to be revised here, as you see. We take a lot of care in making sure of notes, as you've seen with the multiple checks, that we've actually placed the electrode, i.e. the lead, in the correct location. And this needs to be pointed out that and well documented that these rates may be and likely are even higher in centers that do not produce or do a large number of surgeries. It's recommended that to be considered a DBS center, you must do at least 20 surgeries in a year, and that otherwise it's been shown that the rates are even higher for complications in centers that do less than 20 surgeries in a year. Stimulation-induced side effects are very common. These, as shown, we induce actually during our programming. And the reason why we induce these is because I want to know how high I can increase, for example, the amplitude, so that we never do it again during the course of the patient's life. We can simply reduce the amplitude, change pulse width, change context to mitigate the stimulation-induced adverse effects, which is really one of the benefits I see in DBS. There are some specific symptomatic management adjustments that are made. For example, in subthalamic nucleus DBS for Parkinson's disease, sometimes an individual may develop impulsivity or depression, and we can target and stimulate then different parts of the brain using that same electrode. Hypophonia has been well shown, and that can be also potentially mitigated by adjustments of the stimulation. Dyskinesias are commonly induced with STN-DBS, and that's we can either do a couple things with stimulation and or reduce medication. GPI is the other target that we kind of mentioned. Sometimes if you stimulate too far down, or we would term ventral, you can block the beneficial effects of levodopa, or if you stimulate too far up or too far dorsal, we can induce dyskinesias. Hence, we can adjust stimulation at that point in time. I thank you all for your time, and I am readily available for any questions, all questions that you have. This is a list, if you wanted to, I'll leave this up, for contacts in order if you had questions, or if we don't know you already and you're interested in getting to know us, you can call and make an appointment at that point in time. Thank you all.
Awesome. Thank you so much for that wonderful presentation. We are going to open up the Q&A now. There are a couple of ways that you can do that. Again, the questions tab on your control panel, you can go ahead and type the questions in there. Or if you'd rather ask your question verbally, feel free to raise your hand and then we can unmute you and you can ask your question directly. While we wait for people to type in some questions, I'll go ahead and ask the questions that were submitted beforehand. So one of the questions is from Mark, who is a person with Parkinson's, and his question is, I read DBS is effective for 10 years. For those of us with early onset, then what? Can't do it twice, and does it limit future treatment?
Yeah, so great question. DBS, as I've mentioned before, is a treatment. It's not a cure. And in fact, the only treatment we know that does slow down the disease, I should have said this earlier, is actually exercise. Hence, every patient I see, we always spend some time talking about exercise. I don't care what exercise patients do, just as long as they do some form of exercise, because the studies have shown from Tai Chi to weightlifting to endurance activities, all of these have been shown to be beneficial for delaying or slowing down the progression of Parkinson's disease. With regard specifically to the question, so 10 years, that's one. There's other studies that even show that medications start to need to be added back as soon as 3 years, or even certainly need to be adjusted, added back at 5, 6 years, if, for example, was an STN DBS. When I have patients say that it's not working anymore, it's not effective, I simply can show them that it is by turning off the device. Lo and behold, they're dramatically worse. And so the point being is it still very much works, it's still very effective, but it's not as effective as it used to be. And that's because it doesn't affect the disease course. The disease is relentless and continues at that point in time. Tend not to make a lot of stimulation adjustments, by the way, after 1 or so years, unless there's a specific symptom that I'm trying to mitigate. Medications are then added back, and there's even talk and discussion that one of the best treatments might be DBS. And the later course in the disease, you have a continuous infusion treatment, for example, with Carbidopa, levodopa subcutaneously, that is able to be adjusted. So, although it's certainly correct that medications need to be eventually added back into the medication regimen, given the fact that this is not a cure, but another form of a treatment, I do believe that patients even late into the disease course do notice significant benefit with DBS. And we do see that, for example, even patients who have had DBS for years and will require, for example, battery replacement, they do note that if all of a sudden the battery was to die, they're dramatically worse, and they come in for a battery replacement at that point in time. So I hope that kind of answered that very, very good question.
Great, thank you. Another one that was submitted from Ellen, who's a family member of a person with Parkinson's. She says her dad takes 11 Rytari and 8 milligrams of Nupro daily. Tremor is still not controlled and won't do surgery. I know you touched briefly on some of the alternatives in your presentation, but could you go just really quickly over some of the other options?
Yeah, so tremor is one of those treatments that is improved by 75 to 90% by surgery, by DBS. And there is tremor-resistant Parkinson's disease, or tremor-resistant refractory medication Parkinson's. So that's one of those that we can try a number of different medications, but if I'm already up to kind of the dosages that you're talking about and still not getting the benefit that we need for tremor, that's when I'm kind of already thinking about the advanced treatments that we talked about. Doing, for example, DOPA or subcutaneous infusions isn't going to do any good because the patient's already on carbidopa, levodopa, not having the benefit. You can try some alternative medications, and that might include, for example, a dopamine agonist that you're already on, but again, that might not improve symptoms. Sometimes an anticholinergic, trihexyphenidyl, may be tried, but there is adverse effects of that medication. We may try specific tremor medications, primidone, propranolol, gabapentin as an example that may provide added benefit. But sometimes if they have a really significant tremor, as you saw from that one patient in the video, no medication is really going to be at least effective enough to render that patient have functional benefit with that. And then rarely, sometimes we'll even try toxin injection or Botox injections, botulinum toxin injections into specific muscles of the arm. That may be of benefit. We are in the process right now in discussion of having a clinical trial looking at botulinum toxin injection. However, that is for essential tremor and not necessarily for Parkinson's disease. So sometimes we may try those options. If the individual, for example, we determine has concerns for cognitive impairment, we may at that point in time, despite the patient having Parkinson's disease, offer, for example, only to target the thalamus as an alternative, knowing that yes, it's not going to help with the rigidity and maybe won't help with the slowness of movements, but the tremor is the main symptom, and targeting perhaps only the thalamus may carry theoretically slightly less risk of developing any form of cognitive impairment in doing it on one side. And then also, we may also look at focus ultrasound in such an individual if indeed DBS is really off the table given notable exclusion criteria.
Great, that was perfect. She actually wrote in and said that he had some cognition issues, so that answered it very well. A question from Teresa. She asks, does Kaiser refer patients for DBS to you?
Well, Kaiser is an excellent DBS center. Kaiser in Denver. Adam Hebb is a neurosurgeon who's there. He's excellent. And Abram Kurtz is a movement disorder neurologist there, and he's fantastic as well. They are a very good center. They do a number of patients, have a lot of experience, and are well trained. So if you're in the Kaiser system, I would say making an appointment with them is a very good option. As I do respect that group very well, and they have a multidisciplinary team as well and do a number of surgeries per year and have done a number of surgeries per year, have experience in patient selection as well as in programming for patients. So that's a good option. I do have a few patients who will see and check in every once in a while. But again, that then becomes challenging with regards to insurance coverage and Kaiser actually paying versus now patients have to pay out of pocket. Of course, I see none of that, but that becomes one of the limiting factors.
Great. So I don't see any other questions coming in. I'll kind of keep talking, and if anything else pops in, I'll let you know. But there will be, just a reminder, there will be a follow-up email tomorrow that'll be sent out around this time. Otherwise, thank you so much, Dr. Kern, for taking some time out of your morning and presenting for us.
Oh, my pleasure. Thank you very much for this opportunity. I always enjoy teaching, and I hope that this was of benefit to others. Thank you.
Yeah, thank you so much. I hope everybody stays safe.
Bye-bye. Thank you.
Bye.
Bye.